Today we will discuss the surgical management of the discoid meniscus. This MR image demonstrates a very large discoid meniscus involving the lateral compartment of this 7-year-old girl. She was having significant pain laterally, and you can see that there's actually extrusion of the discoid meniscus beyond the normal space that a meniscus fills laterally. On the next MR sequence, you can see that there's even evidence of a horizontal cleavage tear or possibly cyst formation noted by the high signal intensity more medially within the discoid meniscus. In the third sequence, which is even more posterior in the entirety of the discoid, it also demonstrates a still very full, very thick meniscus. And this is a good point to demonstrate what a normal looking meniscus appears like by looking on the medial side, and you can see these small, nearly triangular shaped, dark meniscus shapes, which do represent the normal appearance of a meniscus rather than the large bulbous meniscus as seen by the discoid. Standard arthroscopy is started by making the standard portals adjacent to the patella tendon. Cannula is inserted and the camera is attached to the arthroscopy equipment. Diagnostic arthroscopy is performed, assessing all the cartilage through the joint. This is the patella above, working around the joint to the medial side. You can see here, once we get back in focus, that this is a normal appearing medial meniscus. This is a normal appearing ACL. And here adjacent to it to the left is a very large bulbous discoid meniscus. To better see this meniscus, it's important to bring in a probe so we can ascertain what's going on. Here you can see the probe working over the meniscus, and quickly we find that cyst that we noted on the MRI earlier. Plus, as we reach over the top, we see that this fills the entirety of the space of that lateral compartment. It's quite a large discoid meniscus. First, we would use the shaver to see if this is bad enough tissue that the shaver can actually capture the discoid meniscus and shave out that central portion, which is sickly. However, you can see that the shaver is not making much progress. And so we have to resort to a secondary measure, which is using a tympanoplasty blade. We actually have to unbend the blade slightly so it doesn't have quite the curvature that it normally has, as you can see here. And then we introduce this through one of the portals. We then proceed to use this to excise the central portion of the discoid meniscus. We do this very cautiously, being sure not to cut any of the articular surfaces, protecting the cartilage both above and below. We have to work both sides on this particular discoid meniscus because it is quite large or quite thick. This is not always the case, and oftentimes the more thinner discoid menisci can be excised without as much work being done. Once we work the front or anterior portion of the discoid, we then can move to work on the back or posterior side of the discoid, being sure not to excise too much as we want to work from the most central portion towards the periphery. Again, if this was a skinnier discoid, I could use this same blade to connect both the posterior and anterior portions of my cuts, but this one being so large, it's quite difficult to do. So then we bring in the shaver. Now that we have edges because of our cuts, we can actually shave a fair amount. However, the tissue is quite healthy on this discoid meniscus, and so these punches, which are arthroscopic instruments, will then be used to actually take out a majority of the discoid meniscus. You can see how readily they do that, and the yellow tissue that you see there is fat and cystic tissue consistent with having a tear and a cyst within the central portion of that discoid meniscus. We'll work out the central area here, being sure not to take anything that we don't want to leave into the patient. And once we feel like we've gotten a significant amount of the central portion removed, we'll then bring in a shaver, as seen here shortly, to work on smoothing down the edges after we've punched out a significant portion of this central aspect. At first, it appears that there's not much of a cleavage tear. However, as you can see, once we work with the shaver and kind of move all the bitten off pieces to actually provide some exposure and visualization, we will see that underneath here there is still a second leaflet. So there's an upper leaflet and a lower leaflet. And this is not a good situation, as these tend to provide more avenues towards tearing and future complications. Here are the two different leaflets there. Because the upper leaflet appears to be the more stable, as I attested here, it is actually attached to the joint lining or the capsule. I will go ahead and remove the lower leaflet as this one is less functional. In the process of removing it, you'll see shortly, you can see that it does not have any attachments towards the tibia or the leg side, and the normal meniscal attachments are towards the tibia and not towards the joint lining, so you can see just further pathology concerning a discoid meniscus. You can see here that I also use the punches upside down at times, which is being done right now. And then I can change that, move them to the side, or extract them and return them back in and use them in the right side up fashion as seen here. The difference is in the way that the biter opens up. It will grab different amounts of tissue and in different orientations, which is important when we're trying to contour this meniscus to make it as anatomically shaped as possible. Once we've completed all the biting that we want to do, being sure to leave a good healthy remnant both posteriorly in the back as well to the side, anterior to the front, we then proceed to use other punches. This one here is a side punch. You can see it has a much shorter mouth, therefore is unable to take quite as big a bites as the previous punch was doing as it tries to nibble away there. I can also use it upside down as seen here, but this one is an important punch to utilize to get the more anterior or front aspect of the meniscus. Ultimately, we bring back in the shaver to smooth down the contours from the punches. And then we assess, being sure that everything is nice and stable, that there's no loose flaps, no loose issues, that the meniscus is not going to dislocate or cause us any problems, that tearing will be unlikely, making sure we've left remnant in the anterior aspect as well. Ultimately, seeing that we've left what appears to be as close as possible an anatomic reconstruction of this meniscus. Here in a slightly different view, we see during flexion extension that the meniscus may potentially still get trapped underneath during deep flexion, but for the most part it appears to be ranging well, and she now has a well-contoured meniscus. Thank you.